Hey, future RN. You know, beta blockers are one of the most tested cardiac medications on the entire NCLEX. I mean, they pop up everywhere. Hypertension, heart failure, post-MI, you name it. So today, we're going to break it all down piece by piece so you can walk into your exam and answer those questions with total confidence.
And listen, if you're feeling even a little bit overwhelmed, trying to keep all these cardiac meds straight, just take a deep breath. I get it. It's a lot. But you are in exactly the right place to make it all click.
We are going to master this entire class of drugs with one simple little trick. I just want you to remember that beta blockers are the LOL drugs. Why? Because their generic names almost always end in LOL. Think Metoprolol. All right, let's dive in.
To really understand beta blockers, you just need to grasp one single core concept. I want you to picture them as putting the brakes on the heart.
That's really their whole job. They block beta receptors in the heart, which is like sending a message that says, hey, slow down, pump with a little less force, and just take it easy. This reduces the heart's workload and its need for oxygen. It's kind of like telling an engine that's been running way too hard to finally take a much-needed break.
And that LOL name, it's not just a cute memory trick, it's your built-in safety check. Just think of the two L's as standing for two lows, low heart rate and low blood pressure. And this is non-negotiable. Before you ever give one of these drugs, you absolutely, positively have to check the patient's heart rate and their blood pressure.
Now, you know those pharmacology exams love to throw these super fancy tropic terms at you, right? Don't let them intimidate you. We're going to translate them into plain English right now. Since we're putting the brakes on the heart, everything is negative. So negative chronotropic, that's just a fancy way of saying a slower heart rate. Negative inotropic, that just means a less forceful squeeze. And negative dramatropic, it just means the heart's electrical signals are traveling slower. See, it all boils down to the exact same thing. The heart is working less hard.
Okay, I need you to really focus in here because this next part is pure high-yield NCLEX gold. To remember the most dangerous side effects, the ones you will absolutely be tested on, we're going to use the 4 Bs. Seriously, if you can lock these 4 things in your brain, you can handle almost any beta blocker safety question they throw at you.
So here they are: bradycardia and low blood pressure. Breathing problems, bad for certain heart failure patients, and blood sugar masking. Let's break down each one.
First up, our first B, bradycardia. This is probably the most common and most tested side effect of them all. And the NCLEX rule is simple. If that heart rate is less than 60 beats per minute, you hold the drug. You stop right there and you notify the doctor. It just means the brakes are working a little too well. And this first B also covers low blood pressure. The general rule of thumb here is to hold the medication if the systolic blood pressure is less than 100. And because that blood pressure is lower, a huge teaching point is to tell your patients to change positions slowly, to prevent dizziness or fainting. That's our good old friend orthostatic hypotension. Okay, the second B stands for breathing problems, and this is where we have to be specific. Here's an easy way to remember it. You have one heart, so that's where your beta-1 receptors are, but you have 2 lungs, and that's where your beta-2 receptors are. Now, some beta blockers are selective and only hit the heart, but the non-selective ones, they block both. And when they block those beta-2 receptors in the lungs, the airways can clamp down, leading to bronchospasm and wheezing.
So let me be crystal clear about this because this is a massive safety issue. You never, ever give non-selective beta blockers like Propranolol to patients who have asthma or COPD. Why? Because you could literally trigger a life-threatening asthma attack. This is not a watch them closely situation. It is an absolute contraindication, period. Our third B is that these drugs can be bad for heart failure patients. Now, I know what you might be thinking. This can be confusing, right? Because some beta blockers are actually used to treat chronic heart failure. The key distinction you need to know for the NCLEX is that they can make new or acutely worsening heart failure so much worse. So what are the red flags we need to be watching for? Well, think about what happens when the heart pump starts to fail. Fluid backs up. You'll see it as new swelling or edema in the legs. You'll hear it as worsening crackles in the lungs. You'll measure it as rapid weight gain, like 2 pounds in a day or 5 pounds in a week. And you might see it as new jugular vein distension or JVD. Any of these signs means things are going in the wrong direction, and you need to report it right away. And finally, our fourth B is for blood sugar masking. This is so critical for your diabetic patients. Beta blockers can actually hide the usual warning signs of hypoglycemia, the shakiness, the racing heart, the anxiety. The body's normal alarm system for low blood sugar gets silenced, and that is incredibly dangerous.
This is why we have to teach our diabetic patients to be extra diligent and monitor their blood sugar very, very closely.
All right, you have absorbed the core concepts and the big dangers. So let's put that new knowledge to the test with a quick little NCLEX-style drill, just to see how well it's all sticking. You ready?
First question. Your patient is prescribed Metoprolol. What are the 2 vital signs you absolutely must check before you even think about giving that medication? Think about the name, Metoprolol.
You got it. It's heart rate and blood pressure. Remember, Metoprolol ends in LOL, and those double L's are your built-in reminder to check for a low heart rate and low blood pressure. Awesome.
Okay, next one. A patient has a prescription for Propranolol, which you know is a non-selective beta blocker. Which underlying condition in their medical history would make you stop, question this order, and call the provider?
And the answer is asthma or COPD. Because propranolol is non-selective, it's going to block those beta-2 receptors in the lungs, putting the patient at serious risk for a dangerous bronchospasm. You are doing great.
Okay, let's wrap all this up with a final cheat sheet. This is the perfect slide to screenshot, so you can use it for some last-minute review right before you walk into your exam.
So here it is, all in one place. Beta blockers end in LOL. Their action is to put the brakes on the heart. You always check the heart rate and blood pressure before giving them. And you never ever forget the 4B dangers: bradycardia, breathing problems, bad for worsening heart failure, and blood sugar masking.
I'm telling you, if you can walk into your exam holding on to these 4 Bs, you are going to be in fantastic shape for any beta blocker question they can possibly throw at you. You get the main idea, you know the biggest dangers, you are so much more prepared than you think you are. You've got this.
And that is our deep dive into beta blockers. I really hope breaking it down like this makes it feel so much more manageable. If this helped you out, hitting that like button and subscribing would mean the world to me. It just makes sure you won't miss our next big NCLEX breakdown. Now for one last question, drop me a comment below and tell me, what's the 1B from our list that really stuck with you, the one you'll never forget? I honestly love reading all your responses. Keep up the amazing work, you are doing great, and I will see you in the next one.